Thank you. So good morning, everybody, and welcome to Department of Medicine Grand Rounds. It is my great pleasure today to introduce our speaker this morning, Dr. Barbara Jung. Dr. Jung is professor and chair of the Department of Medicine and holds the Robert G. Petersdorf Endowed Chair in Medicine at the University of Washington. She's also an adjunct professor in the Department of Biochemistry there. Dr. Jung earned her medical degree from the Ludwig Maximilians University in Munich, Germany. After a postdoctoral fellowship at the Sidney Kimmel Cancer Center in San Diego, she completed a residency in internal medicine and clinical and research fellowship in gastroenterology here at UCSD. She accepted a faculty position at UCSD in 2004 and became assistant program director for the GI fellowship program in 2006. She was recruited to Northwestern in 2009 and to the University of Illinois in Chicago in 2013 as the Thomas J. Layden Endowed Professor in Digestive and Liver Diseases and the Division Chief of Gastroenterology and Hepatology. Dr. Jung's research interests are in colorectal cancer, tumor genetics, and activin signaling and tumor progression. And she studies colon cancer progression and metastasis in her lab. Her research in acute pancreatitis focuses on the relationship between activin signaling and inflammation. She is the PI on an NIH NCI-R01 studying the role of activin and TGF-beta in mechanisms of colon cancer metastasis and has authored 70 peer-reviewed publications. Her clinical focus is on the diagnosis and management of patients with Lynch and polyposis syndromes, and she leads a multidisciplinary, personalized, high-risk GI clinic with an associated clinical and tissue registry. Dr. Jung has been an active member of the American Gastroenterology Association, serving in numerous leadership roles as vice president, then president-elect, and is set to become the AGA president in 2023. And she will be speaking to us today on activin signaling in GI disease, and it's my real pleasure to welcome her here. Thank you so much for coming.
Thank you, Dr. Barak. Thank you, Simajad, and everyone else who was part of this invitation. I couldn't be more exciting. The only thing more exciting would be to actually be in person, but soon. I was asked to share something personal in the beginning, and the challenge is it being San Diego, there's so many things I could share that I have a really hard time. I'm going to talk a little bit about my bio. So a lot of it is San Diego. So some of these things will emerge there. But I thought I started out by really honestly thanking the institution. As Dr. Barak detailed, I came here after medical school for a postdoc. And when it became time to think about whether I should stay in basic science, which I contemplated, or go back to clinical training, I looked around and was really intrigued by the residencies in the US, and in particularly the one at UCSD, and in particular the physician scientist training pathway. So I applied and I matched, and I will say UCSD took a huge risk on me. They really did. And I will never forget that. I wouldn't be anywhere where I'm at without UCSD, without all the people, many of those in the audience today that took a risk. And I just want to keep encouraging people to take risks on folks. I'm a product of that, and I'm really trying to pay that forward. And I owe a lot to this institution. So with that, I'm going to start. Here's the little CME thing. It's going to come up at the very end as well. But any of you who wants to scan it now, I'm going to advance the slide in just a second. All right. So I thought what I'd do today is I'm going to go a little bit over my bio, obviously then talk about science. And I would be remiss if I wouldn't touch upon opportunities and challenges in academic medicine today. Many of those are ubiquitous. I think those are things that are on most of our minds. And I'm going to end with, I think, a question and answer. So many of you may not know, I'm actually born in Portland, Oregon. So when I interviewed for the position here in Seattle, people try to introduce me to the Pacific Northwest, and I said, actually, I'm coming home because this is where I'm born. This is me up there. I hope this is my first beer. I actually never checked with my parents. But moved back to Munich, Germany at the age of 4. My parents, my dad is an electrical engineer, and he worked for Bonneville Power at the time on the Columbia River Gorge project. And my mom's a college professor. And so she would lead the junior year abroad in Munich for American students. And so all my life growing up, I would see these college kids, you know, at our dinner table. Usually the ones who struggled would be at our house. And to me, being in college just seemed so, I mean, they had beards and they just seemed ancient. And of course now, you know, as our kids are getting there, or many of you have kids already past college, I just think of how young they are. I went to medical school in Munich, and this is going to be music to Ravi's ears. He knows this. My first foray was in esophageal pH monitoring in infants, and that's where I did my clinical thesis in. And in fact, later when I was at UCSD, I worked a bit with Ravi and his group to complete some of those studies. So really enjoyed GI work very early on. I took the opportunity to spend a year at Cornell as a visiting student, which was really foundational. And then when it came time to think about residency, I applied for a postdoc in San Diego in a now no longer existing laboratory that was all based on NIH funding, the San Diego Kidney Cancer Center, Sydney Kimmel Cancer Center. And what I tell my mentees, or when I give mentoring talks, and we think about, you know, have your path, think about what you want to do, what is your passion, questions like, how did you get to work on colon cancer? And I'm going to be honest, at the time, my then mentor in Germany had 2 connections. He was a gastroenterologist, and one was at University of North Carolina working in inflammatory bowel disease, and the other was in San Diego working on colon cancer. And honestly, I picked San Diego. So that's how I ended up with colon cancer, and I still work on colon cancer. As I just mentioned, I then was very, very fortunate to match into the physician scientist track at UCSD. I met my husband, Gerald, depicted there. That's the other story I could have told. He was working on campus. He worked in early academic outreach. After completing undergrad at UCSD, medicine, he's now an ED physician. Medicine was his 3rd career. So when we met, he had gone to the military and then worked in education and had talked about going to medical school and was just in the process of doing his MCATs, and he was already in his early 30s. And so at age 35, he went to medical school. And when we moved to Chicago, that was indeed his match. So that's where he matched. And we went through a tenuous couple of days where it wasn't clear if it's going to be UCSD or Chicago. And so I was the lagging spouse. My husband matched in Chicago. And so I was very fortunate to end up at Northwestern. I will say that I called up all 3 leading institutions and said, I am moving. Does anyone have a job? Because I'm coming to Chicago. So that's how that went. My clinical focus, as was detailed already, is hereditary colorectal cancer syndromes and genetics. There's a UCSD story behind that as well, which started with a then mustached and very large glasses wearing junior faculty who I met at the VA named John Carruthers when I was an intern. And we were working in clinic together, and he was telling me what he was working on, and I had some background in colon cancer. And I will just say at the time, well, he'll tell everyone also, he was working at the VA for free. So we connected, and this is the lab I joined. And as many of you know, one of John's focuses at the time had been TGF-beta. but nobody had worked on activin. So he sat me down with a whiteboard and he said, Barbara, you're going to work on activin. I mean, remember, I'm a resident at this point. And he had this like long timeline on, okay, you're here, activin, you start this, you know, you're going to be on the T32, then you're going to get your KO8, you're going to add an RO3, you're going to add an R1. And while it all sounded very exciting, I was pretty sure he really wasn't talking about me. But I've always tried to think about the next day and the next day and the next day. So, you know, I sort of had marching orders, and I just worked off that script and just, you know, put my head down and, you know, one day at a time. And here we are. I mean, I hate to tell John that he's right, but it worked out. And again, somebody I'm really grateful to. At the same time, and Tom Savidis knows this very well, the fellowship, I think John was doing the fellowship, and then he was interim division head, and so they needed help with the fellowship. So I was very fortunate to actually help with education, learned a lot, and also was fortunate to help with the PSDP, which that's one other pearl, I would say. A lot of these things come full circle. We're in the middle now at UW of really building a robust PSDP, and I'm so grateful of all the experiences I've had, having been a graduate myself, and then also helping with the program. So in 2006 in Chicago, my daughter Zoe was born. I already mentioned 2009 that we moved to Northwestern. 2012, Timothy was born, and this is an older picture, but Timothy, especially during COVID, got longer and longer hair. And we were on a recent flight, and somebody said, "You have two beautiful girls." So he's not a fan of cutting his hair, but anyway, I do have the second one is a son. So in 2013, there was an opportunity in town to take over the division at UIC, as was mentioned. And then since 2019, we've been in Seattle. On to the science. So I do not have to tell this audience that colon cancer remains extremely common and is also still a huge source of mortality in Americans. Some of these numbers are shifting, and particularly now with COVID, but suffice it to say that at least 50,000 or more of those diagnosed with the disease still die of the disease. If you look at different charts, second leading, third leading, depending by gender, but high up there in terms of cancer-related deaths. For us gastroenterologists, very important, and for primary care physicians, it is preventable at early stages. And I would posit that there's going to be very few people in the audience who do not know someone who was diagnosed with colon cancer, probably even pushing it further, who do not know someone who was diagnosed recently with colorectal cancer. Going to push even further, someone who was diagnosed with colorectal cancer who probably could have been diagnosed earlier. A lot of the work we're doing is based on the premise that knowing the tumor genotype may be key to predicting how someone will do with colon cancer and tailor specific treatments. So what is the genetic background of colon cancer and the susceptibility? And this is an old graph, but it still holds very true. And I like it because it really shows the distribution of genetics of the colorectal cancer predisposition syndromes and others that we see. So if you look at the pie chart, the vast majority of colon cancers still are sporadic, and sporadic meaning that there's no discernible family history. Now, there's a subset in those that is actually leading to a lot of concern amongst oncologists and others that are younger, no family history, and present with advanced disease. And the field is studying this feverishly, trying to figure out what are the components that lead to this. And so more to come. But within that sporadic is a big group of high morbidity, high mortality, young folks that are hard to predict. You all know that the screening age was lowered in part because of that data, but some of the folks we see present as early as in their 30s. Then there's the familial group with somebody, first or second degree relative with either colorectal cancer or polyps. We all know that influences the individual risk, but again, to varying degree. And then if we go to the left on the pie chart, Lynch syndrome is actually quite common. And so any primary care physician with a large panel has Lynch syndrome patients just by mere statistics. And so a lot of effort has gone into trying to identify Lynch syndrome patients before they present. Now, these smaller pie charts are the very interesting polyposis syndrome and hematomatous polyposis syndrome. They're pretty rare, but have very distinct phenotypes, not that easy to miss, and are very interesting to study. Yet remember that in the overall scheme of things, fairly rare. So I'm going straight to Lynch syndrome management. You could do a whole talk on Lynch syndrome, but I thought for this audience, just to sort of give an overview again on how little we actually really know and how little is evidence-based in terms of how to manage those patients. When someone's diagnosed, we start with an individualized plan of surveillance, and the idea is to, well, hopefully never find a cancer, which does happen with some. Not every Lynch syndrome patient will have a cancer in their lifetime. But if there is a cancer, to find it early, so it could be treated early. So the plan gets put together, and it involves an array of interventions. Colonoscopy, usually every 1 to 2 years. Important to note that here the evidence is really based on fairly weak evidence, some cohort studies and a lot of other expert opinion. I want to draw your attention to endometrial biopsy and hysterectomy. Those are actually the hardest discussions with female Lynch syndrome patients. So this might be a new diagnosis. We'll talk a little bit how you might end up with a diagnosis on Lynch syndrome. But very quickly, there's going to be a talk about family planning, how many children, it might be someone who hasn't had kids yet and they're planning on children. So because hysterectomy is recommended after childbearing. So those are big discussions for female Lynch syndrome patients. The other one that remains very challenging is pancreatic cancer, because there's an increased risk. It is unclear that screening actually makes a difference. Most institutions alternate MRCPs with EOSs. There's a lot of incidental findings that come up with this. There's a lot of anxiety. And it's very hard for patients to not do this if they had an aunt die from pancreatic cancer and have Lynch syndrome. So these are some very personal discussions. Each patient is different. I have patients who by 8 months are ready to have their colonoscopy and they wish they had it earlier. And there's patients who really say, the further I can push this out, the less interventions I have, the happier I am. So, and sometimes those are within the same family. So everybody has a little bit of a different plan, and those plans may change over time. So just looking a little bit about the genes associated with some of the classic polyposis syndromes, mainly because when we look at how to study colon cancer, a lot of this can be very insightful, and we have some mouse models that mimic those. So the classical syndrome is FAP. It's a germline mutation in APC. So classical, thousands and thousands of polyps, can't be missed. Attenuated, still hundreds of polyps. And the difference between classical and attenuated is where the mutation in the gene is located. MUT-YH is autosomal recessive, can look similar to attenuated FAP. Difference again, autosomal recessive, one allele from each parent. So about 1/4 in kids may have it. And so that's an important thing to think about when looking at family history. And then there's others. PPAP is FAP-like. Again, you see other cancers popping up here also, endometrial cancers, POLD and POLE mutations. Still grappling with serrated polyposis syndrome. Genetic basis as of now unclear. Probably not a straightforward one. And then the hematomatous polyposis syndrome, juvenile polyposis, Peutz-Jeghers, and P10. If we have residents in the audience, I would study those. They're on every board. Every person who gets asked to write board questions writes those about Peutz-Jeghers and juvenile polyposis. Ripe for question. So again, for internal medicine audience, I needed to talk about gene panels and why this is pertinent to all of us. There's more and more panels. You all have patients who come in who've had panel testing done or relative had panel testing done in some shape or form. And we have gotten away from being able to counsel for all possible outcomes. So typically informed consent, you talk about what the intervention is and what the outcomes could be, and then you undergo the intervention. Now, with genetic panel testing, sometimes the panel was already done. And also, given the variety of genes and follow-up from the variety of genes, we're not able to counsel for all those outcomes. A very common outcome is variants of uncertain significance. We call them VUSs. And they're more common than known mutations. They're everywhere. It's basically just a mutation that we don't know what it means. And so that can lead to a lot of confusion. In fact, can lead to a lot of anxiety. There is data from the psychology field that not knowing is harder than having a bad outcome. So usually those get reposited, and then over time, if there's association with an outcome, they get reclassified. So all this data is being collected, but for a patient, when they hear, well, there is some sort of mutation, but we don't know what it means, stay tuned, can be very challenging. Minor frequency mutations, so you have something, but we don't know what it means. It might be a little bit, well, we do your colonoscopies. Should we do them more often? Does that add to your family history? Difficult discussions. And then the unexpected mutations, which happens all the time. So you might find BRCA when looking for hereditary colorectal cancer, a CDH mutation, a very vexing one for gastric cancer when looking for hereditary colorectal cancer. So the surprises and how to prepare for that. So all of us grant writers think of significance, and I could not think of a topic that is more significant than genetic testing in these days of doctoring. But those principles are not so basic. So it's really important that we train ourselves, we train the trainees, we really stay on top of understanding what our patients are getting in terms of information, how we interpret it, and how we make plans with that information. Barriers between specialties become fluent. I think we're still, and I think about this from my vantage point with a big department, we have all these different buckets of your gastroenterologist, your cardiologist, and a lot of it has to do with the work we do. So, particular procedures or, what particular specific patients we see by diseases. But then now with this, there is fluidity. So, already my cohort touches a lot of different specialties. And so I think we're going to see more and more fluidity between that. We're already doing, we have realized that we have to have clinics that we call multidisciplinary. I think the next step will be really patient-centered and thinking about what a patient needs in a particular condition. These patients with cancer predisposition allow truly personalized approach to care. I talked about that when thinking about a screening plan. And it's a very rewarding health literate population. They've helped me so much generate questions and really have informed my basic studies. So if anyone is looking for a great population to interact with, I can highly recommend it. So onto the genetic changes within colon cancer. So again, this is an old slide. A lot of it actually holds true still. So the thinking currently still is that when we're going from the normal colon to adenomatous polyps, there usually is a gatekeeper mutation. And you see in the bottom, so the germline APC mutation, as we talked about, leads to FAP. This doesn't have to be germline. This could be sporadic. So basically in various genes of somatic cells, that gene can be either mutated. I've noted here loss of heterozygosity, or it can be hypermethylated. So in any event, the function of APC is perturbed, leading to adenoma formation. And then we have two known described pathways of genomic instability. The top one, more common, chromosomal instability. The majority of what I showed in the pie chart as the sporadic cancers. However, it's been around for a while, it's been recognized for a while. It's a pathway where bits of chromosomes get rearranged, and that's why you have aneuploidy and loss of heterozygosity. And that that affects genes. So it activates RAS, P53, a tumor suppressor, gets inactivated. Interestingly enough, we've not really learned a whole lot more about the mechanism behind chromosomal instability. So it's proven difficult to study, difficult to recapitulate. So again, up for grabs for someone. The lower one, microsatellite instability, is much better studied. It is a mechanism where microsatellites that we have, both intronic and exonic, the repair mechanism is inhibited by a specific mutation, and it leads to this hypermutable phenotype, and lots of genes are associated. And here we see, so TGF-beta2 was one of the genes. And when John pulled me in his office, he said, you know, activin has 2 microsatellites that are coding. You should look at that. And so you see here in blue, it's a little bit of a spoiler alert. Yes, it was mutated and had functional consequences. So this is where my work on activin began. So having them side by side, the TGF-beta family members is quite complex. So on the top, I listed the ligands, so activin, TGF-beta, and the BMPs. And there's quite a bit of promiscuity, you see. So there's different ligands can bind to different receptors, which makes studying quite complex. I've highlighted the ones that are known to be important in colon cancer. And if you go from the left to the right, so activin ligand binds to its primary receptor, actin receptor 2, which in turn binds to actin receptor 1 and phosphorylates activin receptor 1, that then phosphorylates SMAD2, associates with SMAD4, translocates to the nuclear, and affects gene transcription. Now, interestingly enough, the same occurs with TGF-beta. It has its own set of primary receptors, but then also signals between SMAD2 and SMAD4. BMP comprises of 3 different ligands, multiple receptor combinations, uses SMAD1 and 5, and then uses SMAD4 downstream. So how does this affect colorectal cancer progression? So again, I graphed a microsatellite stable on the top and microsatellite unstable on the bottom. And data that I will show solidified our belief that it's indeed important in the adenoma to carcinoma progression, but future data made us think about the effect in carcinoma to metastases, which is really the key part when you look at how to affect outcomes and decrease mortalities. If we only had locally growing tumors, those would be curable, and particularly in colon cancer, they can be resected. So, okay. So some of the work we've done, again, on the right-hand side, the same graph with the BMPs on the left, TGF-beta in the middle, activin on the right, signaling to the left through the canonical SMAD signaling. But then, as I will depict in a second, there is non-canonical signaling that might be actually pro-migratory. So some of the work we did. So this is the first work I did as a fellow in the lab with John. So indeed, I was able to show that actin receptor type 2 was mutated, and it affected protein expression in microsatellite unstable colon cancer. So we talked about that. We then went on to look at whether this is also important in microsatellite stable colon cancers. And indeed, we found that it was disrupted by also genetic and epigenetic mechanisms in this other set of cancers. Remember that these are the sporadic cancers. So that led us to believe that activin is an important pathway, regardless of the mechanism of chromosomal instability. We then sought to understand how activin receptor 2 receptor may predict outcome in colon cancer patients, and particularly how it pertains to metastases. And there was a very interesting article at the time by Watanabe et al. In the New England Journal, where they looked at MSI cancers and TGF-beta mutation and found that actually if TGF-beta was mutated, the outcome was better. So this led the field to think about a molecular switch where activin, what we posited, activin TGF-beta signaling initially was growth suppressive, and then led to a pro-migratory phenotype at later stages of cancer, which of course makes it very vexing if you think about treating, because if you would inhibit growth suppression early on, you would posit that you would get bigger tumors. So, but in any event, this is what we found. And in the beginning was challenging because the field very much felt dogmatic about, is something a tumor suppressor? You must still read this. This is a tumor suppressor. This is an oncogene. And I think folks are really appreciating now that a lot is context dependent. So the same molecule can have multiple functions depending on the context, depending on the downstream signaling, as depicted here on the right. Canonical SMAD is growth suppressive, but if canonical SMAD is interrupted, it can be pro-metastatic. So this is some of the work in this paper. And then we started to think about, well, I showed how similar activin and TGF-beta work downstream. So we started to think about, well, why is that? And why would you have two completely separate redundant upstream mechanism when it all flows through the same downstream signaling? And so we try to dissect down what are those diverging signals? And we found that there's some specificity by which activin and TGF-beta signal, especially in advanced colorectal cancer. And one of the downstream effects of this is P21. So we did some work dissecting down what role P21 plays in this. And circling back to TGF-beta, we then started to think about how does this affect the environment around it? And we're able to show that there's associated inflammation with loss of TGF-beta signaling using a variety of mouse models. And finally, that this microenvironment also affects, is also important in pancreatic tumors. So TGF-beta signaling in the pancreas leads to fibrosis and immune evasion and worsened tumor genesis. So speaking about the tumor environment, in the 90s, when we started looking at this, a lot had to do with, a lot of focus was on the epithelial cell, the genetic changes within the epithelium, you know, how does the cancer grow, what mutations does it acquire? And data in the early 2000s started focusing on the host immune response. I just wanted to show one of the really sentinel publications at the time, looking at peritumoral immune infiltration, and that you basically could just take a slide of a colon cancer and count the immune infiltrating cells, and that would predict outcome. Now, I need to tell you that microsatellite unstable tumors, for reasons that still have not been explained, has a much more robust immune response, so it correlates with that. But suffice it to say, it became highly clear that activating the host immune response is very important. The interaction between epithelium and TME is very important, and particularly in advanced disease. So all of you know that there's been huge advances in harnessing the host immune system. Here's an example. I'm showing PD-L1 blockade, and it showed great promise in MSI colorectal cancers. Now again, those are the ones who already do better, that already have an activated immune system. And I'm not going to go over panel A and B, but I can summarize that the tumors that do worse to begin with are immunologically less reactive. And that is also true. And I don't know if it's specifically referenced here, but for pancreatic cancers, the immune cold pancreatic cancers do much worse. And so a lot of interest currently has emerged in how to awaken the host immune system. How is that interaction between the tumor cell and the microenvironment? Does the tumor silence the response? Is it a host predisposition that leads to these immunologically cold tumors? It really extended the studies from the epithelium to the whole environment. In fact, in many ways, many believe now that the tumor microenvironment is the conductor, and the tumor cell is really just following the instructions of the microenvironment. So this is sort of where we're leading with our current hypotheses. You see the tumor cells here in the middle, and then you see immune cells and cancer-associated fibroblasts that are very, very important. They secrete cytokines. They can make stroma and lead to fibrosis, which I'll show you some data why that is important. But there's a lot of feedback loops back and forth. A lot of them involve activin. There's immune modulation. There can be growth suppression, but also proliferation and migration. So this is sort of where we find ourselves at. As you can see, lots of variables, lots of context to study. And lots of challenges when you think about how to attack a specific tumor. So one thing we thought about when we looked at the complexity of these graphs is there a way to actually think about this outside the box? So I just said earlier that, you know, we looked at just epithelial cells. So we want to expand it to the TME. But we also noticed that, and we're not the only ones, obviously, that, you know, there's a lot of, the microenvironment can look very different. So in pancreatic cancers, especially the really malignant ones, it is extremely fibrotic. Colon cancers can be very fibrotic also. And so we were thinking, is there anything mechanical? Have we thought about the physics in that environment? What leads to what? And we were very fortunate that we started a collaboration with a bioengineering group that is at Urbana-Champaign in Chicago. The idea was, when we go from normal extracellular matrix to increased stiffness and less elasticity, this is accompanied with increased invasion and migration. But what is the causal effect? So this group made these tiny prototypes with different pressure, and we were able to have cells migrate in stiffer and stiffer environments. And in fact, I'm going to summarize some of the data. We were able to show that this biomechanical forces can actually lead to increased secretion of cytokines. And we're very excited about that because we felt like we had made another link between a physical property and a biochemical property that we don't always think about when we assess a tumor. So again, thinking of new ideas and other ways to assess. Now that, of course, anytime you think about tumor microenvironment and multiple cell types, we're very dependent on mouse models. And so I'm not going to go over all of those in detail, but you will see some that are very well known, APC, and then we added in TGF-beta alterations as well as KRAS and SMAD4. And then we have a bunch of pancreatic models as well. Again, KRAS driven with TGF-beta and SMAD4 flocks in. So when we look at pancreatic cancer patients, we find, and this is in accordance with our hypothesis, that expression of stroma activin correlates with reduced survival in pancreatic cancer cells. So if activin indeed supports migration, then you would expect that high activin is associated with cells that migrate a lot, and pancreatic cancer is very metastatic. So this is a TMA of 63 pancreatic cancers, and we looked for activin in epithelia and stroma, and found that higher activin in both epithelium and stroma was associated with worse outcome. So we all know also that pancreatic cancer and colon cancer are not the same. Actually very challenging for folks in the field to draw correlations, and I think most would agree that there is a lot of distinction that we don't fully understand. So we went back to a mouse model in colon cancer, and we were able to show that loss of SMAD4 in this mouse model decreases survival and an increase in dysplasia, and that loss of activin leads to decreased tumor growth. So far, this fit with our hypothesis. This is work that's in preparation, so I'm showing you hot off the press. And I'm going to show you this because I had to grapple with this for a while. We looked at a very robust cohort, the QUASAR study, in collaboration with Dr. Kern in Oxford, of stage 2 and stage 3 colorectal cancer. So these are early stage. And we were initially hypothesizing that maybe with activin staining, we can see which ones may become more metastatic and have worse outcomes. And can we predict survival? And we're actually seeing the opposite, and it's robust. We looked at it a bunch of times. We're seeing the opposite of what we initially predicted. So in this case, as you see on the left, if you have high activin, your outcome's better in these early stage colorectal cancers. So we're grappling with this right now. One hypothesis, and I'm not going to give too much away, one hypothesis is that indeed at the early stages, this is associated with an activation of the local immune system. So with pancreatic cancer at later stages, possibly the immune system has already been overwhelmed. But I wanted to show this because not everything's straightforward, and this was data we did not expect at all. I'm actually quite excited about it because I think we found something really interesting. So stay tuned. I'm going to switch gears a little bit. I am a gastroenterologist, and so while I was in the middle of some of the activin studies, I was on service, and yet again, my service had, I think, 3 or 4 acute pancreatitis patients, and we're talking about activin, and we're talking about local activation and systemic activation, and here I had all these patients that were very sick, and we were really mostly doing supportive care, and so I was wondering whether activin played a role in acute pancreatitis. And so we looked at a cohort together with Pittsburgh and assessed, activin levels. And lo and behold, activin is increased in moderate severe disease and correlates with worse prognosis. So when we found this, we were super excited. We said, well, we have a marker for pancreatitis. The data was so clean. But we're a colon cancer lab. And so I started calling around the country a little bit, and I said, oh my God, and we're going to write a grant, and we have all these ideas. And people were not very excited. They said, well, it's another marker. We know who's going to do poorly with pancreatitis. This is nothing of that much interest. And so it taught me too that, when you enter new fields, to really start thinking about or fully understanding all the work that's been done in the field before. So we took it a step further, and we used a mouse model of severe necrotizing pancreatitis. So these are OB mice, and they're injected with IL-12, IL-18, and they get severe pancreatitis. It's a high mortality model. And we treated those with anti-activin. It's a ligand. We liked the anti-ligand treatment because, as you saw, receptor treatment can lead to a lot of different outcomes and off-target effects. So anti-activin ligand for us is the way to go. It's well tolerated. It actually has been in clinical trials for cancer-associated anemia. Didn't meet the endpoint of that anemia, but it was well tolerated. So I think it's a very attractive potential treatment. So treated those mice and actually got beautiful results. So anti-activin led to better survival in those mice. Now, every model has their challenges. So what we did with this model is we treated at the same time that we gave the IL-12, IL-18. That is obviously not how it would work for patients. Many times the patients show up within 24 hours or longer of their attack. And so thinking of something that would work even after the initial cascade has unleashed would be important. So those are studies we're doing right now where we're looking more at the timing. And also looking in a broader context around what is it that activin modulates. So inflammation, severe acute pancreatitis, I talked to you about the OB mice. So we said we need to make sure this is independent of BMI. And it is. You see here in A that while there is higher with BMI, it's not dependent on that. And we also use different mouse models, a cerulean model, to really look at how anti-activin affects the local pancreas. And so you see here, it reduced edema when you used anti-activin, percent necrosis, pancreas weight to body weight ratio, and neutrophil infiltration. So all that under our belt. We are actually in the middle of revising an R01, fingers crossed. We have a large patient cohort we're going to look at, and so we're very excited about those ongoing studies. And I shall become a pancreatologist also. So future directions. I hope I've been able to convince you that cancer genetics needs to involve the study of stromal regulation. A variety of cells and cytokines play important complex roles, including in disease precursors. Immunology is everywhere. We can't ignore it. And so we need to do more in-depth studies of TGF-beta activin and the cross-regulation. And that'll help us with the development of new diagnostic and, even more importantly, targeted treatment for GI diseases. Collaborative efforts with distinct patient populations. Again, even the pancreas work, we need large cohorts to test our hypothesis. And as I showed you, working with other disciplines like bioengineering, we need pharmacology, and we need to bring this knowledge to the clinic. So understanding genetic principles is really important. I'm going to go back to that. With big data, AI, and panel testing, these barriers will become fluid. I'm sure of that. Most patients will ask for and need some personalized approach to care, and team science will get us there. So for the last part of my talk, I'm going to switch gears and talk about the future of academic medicine. That's a lofty title. And I'll start with the challenges. And those who know me know that I'm a glass half full person, so there will be opportunities. But I do have to list some of the things that are top of mind for many of us. And so what is it that we're facing? And I don't have to tell any of you, I just threw it on a slide for further discussion. But all the discussion about staying afloat and staying afloat successfully, because afloat is not a very high bar, while true to the mission. And we're all grappling with rising personnel costs, trainees that have high student loans, decrease in reimbursement, tough funding environment. And going back to thinking about what truly is success, we just did a strategic plan in the department where we really sat down and thought about 5 years from now, how would we high five ourselves if we achieved what? And it was a really good process. Lots of discussion, lots of different opinions, but just sort of landing somewhere of which direction do we want to roll. All clinicians everywhere, the increased documentation burden with EMR, we just switched to Epic. a year ago. And so a lot of positives, because at least it's now one system, and so much documentation burden, so much messaging. We're really trying to grapple with how can we help our providers? How can we increase access for patients? But at the same time, how do we keep this manageable? And the healthcare disparities are widening. I think this is very clear. We see it in, as I said, colon cancer, there's a disproportionate, pancreatitis, disproportionate. And a lot of these very complex patients, the coordination of care is largely unsupported. At UW, we have a huge problem right now with length of stay, extremely complex to coordinate discharges, and a lot of this falls on a lot of folks who also have other things on their plate. And provider training and staff burnout, that was true before COVID. And of course, now there's been so much of that we don't even know what the new normal possibly is and how it should feel like. So I had to add COVID, workforce challenges. We just had huge expenses for traveling nurses because we're so down on nurses. We have a residency union that are negotiating right now. And with COVID also really thinking about the educational experience. We had challenges in the beginning of how do we keep rotations going when elective surgeries were canceled? How do the surgical residents get their OR time? How do procedural fellows get their procedures in? And this all in a setting of us all thinking about disparities, social justice, moving forward in a more equitable way. Throw in the NIH funding landscape and overall mental health of all of us. So I said I was going to talk about opportunities. So here they are. I think there are tons of them. So on-demand learning and care, transformative, disruptive technologies. We at UW, when I came in 2019, had done 30 telehealth visits. And in FY21, we did 30,000. So we pivoted. Now we have to sift through the mess of what that is and what it means and which patients to do and how to rein this back in and really do this in a thoughtful, deliberate way. But it was transformative. We are able to pivot. And I think, again, huge opportunity to think about how to build in virtual care. Talked a little bit about the flipped clinic model, truly have it be patient and communication centered. We have so many inefficiencies still when we provide care. So much duplication, so many things that we do that don't make a difference. Network discovery, using the internet big data to expand collective problem-solving abilities. So this is anti-silo, not everyone sitting there trying to work on the same problem. And similar to this, high-resolution health, thinking about health risk and behaviors in precise locations. I think with COVID, we've done some of this. Where are the areas where we have to send people to do vaccinations? Where do we, what are the pockets where we have to test more? So I think we're poised to do that. As a healthcare community, we have to build on that. And then we just have to keep inventing ourselves with rapid prototyping cycles. So implementing and revising what a lot of QI is based around, but coming up with ideas, trying them out, failing, and I'm going to say failing because I think for us physicians, that's very hard, failing, and then moving forward, building upon that idea. So challenges are ubiquitous. I know you face many of the same challenges. I just said we're all in this together, really. There's not going to be one solution. We're working on length of stay right now, and there's still talks should the residents round at 8:30 versus at 9, and that's not going to do it. We need new big ideas. But the people make all the difference and allow for that opportunity. My faith is in all of you, the academic physicians, the thinkers. We're the ones who can move this forward, and the times are asking for that. I'm deeply rooted in the commitment to academic mission. It makes us who we are and fuels us. And change is happening everywhere, which is a good thing. So to me, the future is uncertain, but it's truly exciting. So we delivered some flowers during the pandemic to the janitors. And I'm going to end with this slide. And again, you see the QR code up there. And I'm going to stop and see if there's questions. Thank you very much for having me.
Thank you very much, Dr. Jung. That was absolutely terrific. And you touched on so many different things that are very, very thought-provoking. I'm going to take chair's prerogative and ask one question, and then I do have another question after the ones in the chat. But this is more of how you deal with it. Is there are a lot of people out there getting genetic testing, right? 23andMe and other things. How many patients do you get that come in with that, and how do you deal with those where you're getting this genetic testing in a vacuum without necessarily a family history? What's the approach to that? Because I think that can be very, very challenging.
It's very challenging. And I think the even more challenging is, I think many physicians confronted with that, because it's so challenging, just let it sort of be. And I think it's really up to us and the trainees. And I really think primary care too, because many times it's the primary care physicians who get this, to have a robust network, including genetic counselors, to put all this into context, because it's going to be too much for a single provider to interpret and come up with a true plan that they're comfortable with. But I would say for now, it would be to really pause and think about a network at each institution of, what do I do if somebody comes in with this? Who do I call? We do have a division of medical genetics. We just started a actually training program. So I have a PhD training program in the department for genetic counselors, because they're in super high demand. So I think genetic counselors are your best friends. Might be worth having them somewhere in the clinic so they can pop their head in and actually talk about this. So this will be truly multidisciplinary.
Great. I agree with you. And I think we haven't necessarily paid enough attention to integrating the clinical geneticists into the practice. It's kind of, oh, they're just over there. And there is a tremendous shortage. I agree. So from the Q&A from Dr. Mohammed, thank you, Dr. Jung. Given the high prevalence of colorectal cancer, I'm curious to know if there are any environmental interventions aside from frequent colonoscopies that can mitigate the risk of CRC development in patients with polyposis syndromes or other genetic predispositions to CRC.
Very good question. So I will say, and again, this gets, I think that's when you know you've crossed over to the senior faculty side, when all your answers become broad and esoteric. But I will say to this that ideally we want to increase population health to minimize any of these outcomes. And, in the particular patient with polyps, who already has polyps, it's very difficult to think about environmental interventions to decrease further polyp growth. But what we do know is things to keep your colon healthy. We know Western diet is not good. We know lack of exercise is not good. Basically, anything that's good for your heart is good for your colon. So starting very early with healthy habits, which is the thing that most people don't want to hear. Nobody wants to hear this because everybody knows what they should be doing anyway. This is what, again, the primary care physicians battle day in and day out. And it's the answer. We know that in large populations that have introduced Western diets, the rates of colon cancer and polyposis have gone up tremendously. So diet, exercise, generally moderation, again, another big, much hated word. So all the things that you should do to keep yourself healthy will keep your colon healthy. Now, if we're asking about should they be taking NSAIDs or are there any other things, I think it's never too late to be healthy. So it might be a good point to start talking to a patient and say, look, I found a lot of polyps and, it's just time to be overall more healthy and go over a healthy lifestyle. I don't think the data on non-steroidals is mixed. They do work, but again, we all know that aspirin would have never been approved nowadays if it had gone in front of the FDA. So if there's a lot of it, a lot of polyps, I think if folks have a reason cardiovascularly to be on it, I think that can be good, but I would not prescribe it just for polyposis.
Next question from Dr. Satz. Would you recommend genetic testing for adult adoptees for whom family health histories are unavailable? I think that goes probably beyond colon cancer, but just in general?
Yes, I think a very important point, let me go back to family history, which is such an important tool, can be learned quickly and should be documented, and is really important. So many times I see family history none. It's very important to say person adopted, because family history cannot be obtained. The other thing that's really important in family history is if it was a very small family, like they have no siblings, their parents who died in a car accident, can't be obtained. So I think really putting into context, versus the person who's had, a huge family, and we can really trace, their risk. So it depends on the person. I don't think I would, I know I wouldn't just test every adoptee. It also depends on what they would want to learn, because that's a whole other thing around genetic counseling. What are we testing for? And what are you going to do with the outcome? And again, this gets very personal. Lots of us have different things. This neurodegenerative diseases, me, frankly, I wouldn't want to know. And so I think these are but some people may. So I think these are some really deep discussions. With that patient, I would probably, have a discussion around what their hopes are and what their expectations are and what they're concerned about. And take it from there. The other thing that can come out with genetic testing is, of course, paternity. So we've had those as unexpected results, and more often than one would think. So some of the family secrets come out. And again, it's something to think about. You may learn things that you don't think you're going to learn.
Right.
I know I opened a whole can of worms. So
It's really a question of what is it that you want to know or that you hope to learn. I think,
yes.
Unfortunately, when people go and do genetic testing, they haven't always thought that through. But for me, it reinforces something that's been budding in my brain anyway, which is the need to grow genetic counseling and this is not just colorectal cancer, this is lung cancer, this is everything that we're really going to need to be focusing on that. So we're out of time, and I want to thank you for a really thought-provoking and wonderful presentation, really a tour de force covering all the aspects of basic research, clinical, and then academic medicine. And we greatly appreciate your time and hope to be able to welcome you here in person at some point in the not too distant future. So thank you, everybody, and have a great day.
Thank you very much. Been such a pleasure. Thank you.
Thank you. It's great to meet you. And I will follow up. I'd love to talk some more.